This is a short screencast about pneumonia for the pathology recognition workbooks as part of the PRP module. In terms of understanding pneumonia, it's important to realise the different terminology used and how they overlap and can sometimes be misused in the clinical context. So a chest infection is often referred to quite frequently, and that can be either an upper respiratory tract or a lower respiratory tract infection. So an upper respiratory tract infection obviously pertains to the relative upper respiratory anatomy, so sinuses, upper airway, larynx, etc. So the lower respiratory tract infection refers to the anatomical structures that are classified as the lower respiratory tract. And the difference between the use of terminology of pneumonia and chest infection is that a pneumonia is always a chest infection, but a chest infection is not always pneumonia. So we often refer to acute bronchitis under the umbrella of chest infection as well as pneumonia. And ultimately, they're both transmitted through direct and indirect contact, and both have symptoms of cough, breathlessness, and sort of coryzal symptoms. So I'm just going to go into pneumonia in a bit more detail. So pneumonia is defined as inflammation of the lung tissue due to infection, and that predominantly relates to the alveoli as they become infiltrated with the bacteria or viruses and microorganisms, exudate and inflammatory cells. So ultimately the alveoli no longer have air within them, they become filled with infection and therefore are significantly impairing gas exchange. Now there are three different types of pneumonia that are commonly referred to: community-acquired pneumonia, hospital-acquired pneumonia and ventilator-associated pneumonia. So community-acquired pneumonia is the type of pneumonia that, as the name suggests, is acquired in the community setting, and the most commonest cause is strep. And so most patients who attend a GP clinic with lower respiratory tract infection do not have pneumonia. It's only 5 to 12% of patients attending a GP clinic that actually get diagnosed with community-acquired pneumonia, and of those 5 to 12%, only 22 to 42% are admitted to hospital. And the need for admission is based on the CURB 65 score, and that relates to the relative risk of those patients who are either above or below 65 years of age, and that relates to whether your patients are confused, so that's the C. U relates to the urea levels within the blood, R relates to respiratory rate, and B relates to blood pressure. So depending on the score will depend on whether you're admitted to hospital. Of those patients who are admitted to hospital, relatively few of those need critical care admission, so between 1 and 10% of those are transferred to the critical care units. However, if a patient is referred to the critical care unit for a community-acquired pneumonia, it does have a relatively high mortality rate of 30%. Moving on then to hospital-acquired pneumonia, that's defined as pneumonia that occurs after 2 days of hospital admission. So the important factor is that the pneumonia hasn't been developing prior to admission. So the hospital-acquired pneumonia is a bacteria that is infiltrated following admission. In terms of risk of hospital-acquired pneumonia, that increases with length of hospital stay, as you'd expect. So those patients most at risk of HAP are those that have been admitted for longer than 7 days. Now, in terms of the prognosis and severity of the illness, those patients who get the early onset HAP, so between 2 to 4 days post-admission, tend to have a better prognosis, and that is usually because the type of bacteria that's responsible for the pneumonia is very similar to that of the community-acquired pneumonia. But those that have late onset usually have poorer prognosis because they have more significant, more difficult to treat bacteria such as Pseudomonas or MRSA.